Good morning, good afternoon, and good evening, everyone. My name is Alan Saber. I'm the Director of Metabolic and Bariatric Surgery Service Line at Newark, West Israel, and the Director of Bariatric Fellowship Program there. Also, I'm the Clinical Professor of Surgery at Rutgers School of Medicine. I will be the moderator for Ifso Journal Club today for this month. I'm glad to have with me Dr. David Hazan. Dr. Hazan is Associate Professor of Surgery, Director of Robotic and Minimally Invasive Surgery at Tel Aviv University. Dr. Hazan will share with us his feature article of this month's laparoscopic sleeve gastrectomy in adolescents, 10 years follow-up. This is the first article of such a long-term follow-up adolescent with a sleeve gastrectomy. Before we get started, Manuela and Stephanie, thank you for your help. Manuela will send the questions. We have two multiple choice questions. Would like if you can answer the question, and please send us your comment and your result before and also after the presentation. So the first one, what holding you from doing bariatric surgery in adolescents? A, not familiar with patient selection. B, not familiar with procedure selection. C, not familiar with preoperative workup. D, afraid from dealing with complication in such young age. And E, none of the above, I'm ready to do it. So you can have 1 minute to answer. As you know, pediatric population is rapidly growing in the term of obesity. We have 8.5% suffering from severe obesity, that 4.5 million. So, and as you know, bariatric and metabolic surgery is the most effective modality for treatment. So there's a huge opportunity here for bariatric and metabolic surgery in adolescents. So it seemed to be number one, none of the above. 40% of the audience are ready to do it. 28% afraid to deal with the complication. Let's go to the second question, Manuela. So the second question, comparing the adult and adolescents. Adolescent bariatric surgery is similar to adult bariatric surgery in all of the following except patient selection, procedure selection, follow-up protocol, post-operative diet protocol, pediatric behavior specialist for supportive environment. Have 1 minute to answer. And as you know, the whole idea of adolescent bariatric surgery is early intervention. Intervene early to decrease the chance for persistent obesity and long-standing comorbidity with the resultant end organ damage. Great. So it seemed to be you guys get it right. 41% pediatric behavior specialist for supportive environment. The support environment is very important for adult and pediatric, but it's more important in pediatric. Great. So let's get started. Dr. Hazan, the mic is all yours.
Thank you very much, Helen, and thank you very much to Ifso for giving me the opportunity to share my experience in adolescent bariatric surgery. It's an honor for me to be here with you today. I will be more than happy to answer questions and to share your comments with us after the presentation. The presentation will start whenever Manuela let us do it. Hi to everybody. First of all, I would like to thank Ifso for giving me the opportunity to present our modest work on pediatric bariatric surgery. And I would also like to thank Dr. Saber for moderating this session. It is a great opportunity for me to speak with you today and to share our experience in adolescent bariatric surgery. Before we go deep into the paper, I would like to share with you some information that I got from the literature actually before 2010. And this is important because this is information that there is out there for more than 10 years. And I think that we need to read those articles and to understand that actually obesity is also a problem in the adolescent population, and there is a lot of data supporting what we are doing today. So I think that the first disclosure, or the most important one, is that I am not a pediatric surgeon. I am a general surgeon, and at the beginning it was not easy to operate teenagers. You need to build a team, you need to get the information, read the literature, and be sure that you are doing the best you can for this specific patient population. You know that pediatric patients, obesity among pediatric patients has increased sharply in recent years, and the percentage of adolescents worldwide with a BMI above of the 95th percentile of age and sex tripled. Not less than that, tripled between 2000 and 2015 from 8% to 26%. And I can assume that actually after 2015, the numbers are rising and rising. This is a worldwide problem, and as surgeons and the entire medical community, we need to address this problem and to try to help this patient population. We know from this paper that was published in the New England Journal of Medicine in 2007 that nearly all adolescents with severe obesity will remain obese. 88% will have a BMI higher than 35 as adults, and we know that obesity during adolescence increases morbidity and mortality during adulthood. Obesity-related metabolic disorder has a shorter latency period, a younger age of onset, and maybe can be more virulent. Also, this is based on information from a nice paper and an excellent paper published on New England Journal of Medicine in 2004. We know from the same paper that 30% of the adolescent obese patients met criteria for metabolic syndrome compared with only less than 2% in non-obese adolescents. And I don't need to explain you what will be the impact of this problem during the adulthood. We know from a different paper that was published in JAMA in 2003 that obesity-related comorbidities accounts for a 22% reduction in life expectancy in this group of patients. And this has an impact on life in adulthood population. We know from another paper that was published in Journal of Pediatrics in 2007 that in between 8 to 20% of children with severe obesity has moderate to severe obstructive sleep apnea. 50% of them has central hypoventilation syndrome during sleep, and in between 30 to 60% of all patients who are obese during the adolescence suffer from depression. And this depression is a very, very difficult pathology to treat, especially in this age group of patients. On the same paper, and it was really shocking for me when I read it, they measured the quality of life of those patients, and they showed that they were similar to a different group of patients that actually undergone chemotherapy due to cancer. So this is a very, very not only physical problem, also a mental and social problem that this patient population are dealing with it. And I think that we, as a bariatric surgeon, need to try to help those patients.
So all of us know that we can divide the treatment of obesity not only in adolescents with a conservative or medical treatment and also with a surgical treatment. We know that the conservative treatment, and there is a lot of literature supporting what I am showing to you here, it doesn't work. Okay, I don't know what happened or what will happen with the new drugs in this group of age of patients, but until now there is no data supporting that conservative treatment can help them. So actually, metabolic and bariatric surgery has emerged as the most effective treatment for adolescents with severe obesity, and I think that you agree with me that laparoscopic sleeve gastrectomy and laparoscopic Roux-en-Y gastric bypass are the two surgical procedures that are more commonly used in order to treat adolescents with severe obesity. The problem is that although we are doing more and more procedures and specifically sleeve gastrectomies in adolescents, data on long-term outcomes are scarce, and I think that that's why probably I am speaking here today, because we are trying to show our modest data on this topic. So this is a retrospective cohort study of patients that were operated by myself in between 2012 and 2015. We included in the cohort 46 patients. All of them were teenagers in between 13 years old and 17 years old. We performed only primary sleeve gastrectomy on them. And as you can see here, we had an excellent follow-up, and we follow them 1 month, 3 months, 6 months, 1 year, 3.5 years after surgery. And also, we did a long-term follow-up that actually is longer than 10 years. As you know, all patients completed a nutritional, endocrine, and psychiatric evaluation before surgery. And also a social worker did a deep evaluation of the family environment, school environment, and get all the information that could help the patients before surgery, preparing not only the patient but also the family for surgery, and after that trying to follow them and help them after surgery. This is very important. As you can see here in this slide, the mean age was 16 years old. Around 63% of patients were female. The mean BMI was 45.8, and the excess BMI was 20.8. This is a table that shows the baseline comorbidity. The most common comorbidity was hypertension in around 30% of our patients. 4% of our patients has impaired fasting glucose, 10% diabetes, 13% obstructive sleep apnea, and as I mentioned before, also in our cohort, almost half of our patients came to us already with a previous diagnosis of depression, either treated with medications or also with psychotherapy. And I think that this is a very important point that probably we'll discuss after I finish my presentation. Out of the 46 patients, 31 patients completed long-term follow-up. We have a 100% follow-up up to 3.5 years, but unfortunately, around 32% of our patients couldn't get long-term follow-up. The long-term BMI after surgery was 30.1, with a reduction of 33.2% with a p-value less than 0.001. The long-term total weight loss was 32.3%, and also, and this is, I think, those are good news, almost 70% of our patients achieved a BMI lower than 30 in a long-term follow-up. 3 patients underwent revisional bariatric surgery due to weight regain at 3, 12, and 14 years after the original surgery. In one of them, the indication for surgery was also severe gastroesophageal reflux. This table summarizes the improvement in anthropometric and cardiometabolic parameters at 3.5 years and also at 10 years. You can see here a statistically significant difference regarding weight loss, BMI, and hypertension at 3.5 years and also at 10 years follow-up. You can see the top parameters. We could get an excellent follow-up of them. Regarding fasted glucose level, we can see also a statistically significant difference in between the baseline and at 3.5 years. But unfortunately, we couldn't get the information regarding the labs results at the long term. But at least at 3.5 years, we can see that there is a rise in the HDL from 39.5 to 54.2, and also you can see a drop in the dyslipidemia, total cholesterol level, and total triglycerides level, although there is no statistically significant difference on that. What regarding long-term complications? Well, we have almost 20% of our patients had iron deficiency anemia, almost 10% vitamin D deficiency, and also we have low vitamin B12 in almost 6% of our patients. Interestingly, and actually I think that we are the first one who reported this item, we identified that almost half of our patients still complaining of some degree of alopecia in a long-term follow-up. And you know, in this young population, this is an issue, and actually it affects the quality of life of them. Regarding GERD, as you know, as we know also from the adult population, GERD is an issue after sleeve gastrectomy. 7 patients developed GERD. 2 of them, almost 30%, had minor symptoms, only requiring once in a while PPIs, and they did okay with lifestyle changes. 57% of them required treatment with PPIs in a day-to-day basis. And 1 patient, as I already mentioned before, underwent revision to Roux-en-Y gastric bypass because of gained weight and also a severe gastroesophageal reflux. 7 patients, almost 23% of our patients, underwent laparoscopic cholecystectomy, 2 of them in an emergency way due to acute cholecystitis. Well, as you probably know, this is a retrospective study. The numbers are small, and we have an excellent follow-up up to 3.5 years, but 32% of our patients didn't get long-term follow-up, and it can be, give some bias to our results. I think that we can conclude that this is the first report with more than 10 years of follow-up after laparoscopic sleeve gastrectomy in adolescents. I think that our modest data suggests that laparoscopic sleeve gastrectomy is a durable intervention for weight reduction in adolescents and can improve, at least in a midterm, the comorbidities related to obesity. I think that it is important to stress that this is a multidisciplinary team work. This is not an only surgeon work. We need to add to the regular bariatric clinic a pediatric psychiatrist, a social worker that actually is dedicated to prepare those patients and those families and actually help them after surgery in order to get good results. I would like to finish my presentation quoting Dr. Eric De Maria, who said that treatment delayed may be treatment denied, and in some cases, a crisis invited. Thank you very much for your attention. I will be more than happy to answer your questions, and I hope for a wonderful discussion later on. Thank you very much.
Thank you very much, David. Very nice illustrative presentation. We got a couple of questions, but let's just get started with patient selection. So patient selection, do you follow NIH back in 1991, or you modified your indication now according to IFSO ASMBS updated guideline for patient selection?
Well, let's start saying that this is a cohort of patients that I operated on in between 2012 and 2015. So yes, at the beginning, from the criteria for surgery, it was based on the NIH recommendations from 1991. In between those years, we have a slight problem here in Israel that the Ministry of Health actually let us do surgery only in adolescent patients with BMI higher than 45 or BMI higher than 40 with comorbidities. So we have a reduction in the number of patients that we could perform surgery on them. And later on, like 5 years after that, around 2019 or 2018, we will be able to come back and we offer surgery actually to less obese patients.
Yes, that's great. So I see the update for IFSO is broadening the indication and actually narrowing the contraindication, like for adolescents, with syndromic obesity, development delay, autism, history of trauma, are no more contraindications. So you still can do adolescent bariatric surgery and benefit the adolescents from such long-standing intervention. And also it's coming from the fact that long-term follow-up is very good. We have long-term follow-up, and bariatrics and metabolic surgery is safe and effective. And the workup you mentioned, yeah, you have nutritional workup, psychological workup, and endocrine, and also the patient seeing surgeon. We have similar thing in the United States, but we have something called pediatric medical advisor. So pediatric medical advisor, actually the requirement for MBS QIB, metabolic and bariatric surgery quality improvement program. There's a center of excellence here in the United States. And basically it's a pediatrician with experience dealing with adolescent obesity, and he or she will get more involved with preoperative and postoperative management of patients. Then we have a question from Dr. Jack Hamfis. Jack asking about procedure selection, and do you consider one anastomosis gastric bypass? It's a reversible procedure, and the incidence of internal hernia, he said, is minimal, if any, and this because sleeve gastrectomy is irreversible. How are you going to answer this question for Dr. Hamfis?
Of course. Thank you first of all for the question. At that time, I didn't do neither in adults one anastomosis gastric bypass, so I didn't offer that also to adults. You mentioned in your question that it is a reversible procedure. I agree with you. You mentioned that there is no internal hernia. Well, actually, 2 days before, I did an exploratory laparoscopy due to an internal hernia after a single anastomosis gastric bypass. So, as you probably know, here in Israel, there is an explosion on one anastomosis gastric bypass operation. We do see internal hernias after this operation. And actually, if you ask me if today I offer to a 16 or 17 years old patient and one anastomosis gastric bypass, my answer is not, because there is at least some reports of very difficult nutritional issues on these patient populations, and you need to adapt yourself to the environment you are working. A lot of patients that we operating on, adolescent patients here in Israel, go to the army. After that, we have a little bit of issues following them up during those 2 or 3 years. So I try to be more conservative on them. So my answer is not. I will not recommend in my setting and one anastomosis gastric bypass to teenagers.
Yeah, I agree with you. I have a case I presented a nice video at IFSO Miami, internal hernia, Peterson space after one anastomosis gastric bypass. The second question here, I see your length of stay after sleep is 3.8 days. Do you guys apply any form of ERAS, enhanced recovery after surgery?
Yeah, I think that the length of stay today, nowadays, it's the same like in adults. It's in between 1 or 2 days. Back then, I wanted to keep them in the hospital at the beginning. As I mentioned to you, I am a general surgeon, not a pediatric surgeon, and it was an issue for me to start dealing with with pediatric population. So, for any medical reason, the length of stay was longer, but I wanted to keep them in the hospital just in case. But I agree, it's a little bit longer, usually today it's in between 2 or 2 days.
So the main reason you keep the patient longer, adolescent, because you want to make sure they are okay before they go home and come back as a readmission.
Yeah.
Great. Dr. Hampus has another question about long-term follow-up. Long-term follow-up is very important to document weight loss and improving comorbidities. So what you guys doing to have such a good long-term follow-up? 2/3 of your patients had 10 years follow-up. What you do is no show when I have 3 hours clinic, I'm seeing 30, 35 patients, and sometimes I get a good number, they don't come. Do you guys call them, text them, email them, mail them?
Well, as I mentioned, up to 3.5 years, we had a very good follow-up on them. We had a very good team working on them, including the social worker, a clinical coordinator that actually was on those patients. Also, the medical system is digitalized here in Israel, so it was easy, at least for 3.5 years, to follow them very, very good. What happened after that is that we couldn't reach them. Actually, we tried to reach them during the COVID pandemic, and what happened is that around 10 to 12 patients are not living anymore in Israel, so we couldn't reach them, and a few of them didn't want to come back to follow up. But yes, at least for 3.5 years, we could reach them without any problems, but it was an active work, I didn't do it by myself, but the group did it. The clinical coordinator and the social worker was on them.
Dr. Hampus has another question about alopecia, and he said usually related to vitamin B12 and zinc deficiency. Do you check such element before surgery and after surgery?
Well, we don't check zinc before surgery. We do check vitamin B12 before surgery and after surgery. And as I mentioned, and I think it's wrote in the paper, we had a few patients with vitamin B12 deficiency, and also almost 30% with iron deficiency anemia, that it doesn't relate it to alopecia. For us, it was, it's my personal experience, I never asked an adult patient 10 years after surgery if they suffer from alopecia or not. But in this patient population, we made a short questionnaire, and we asked them, and it was almost 50% of them in a follow-up of more than 10 years complaining of alopecia, and this is an issue. It's 50% of them, and we all has alopecia, and also only around 10% has vitamin B12 deficiency. So I cannot answer scientifically why is that, but this is a fact.
Okay, we have a question from Dr. Islam. He said, how long you get a psych follow-up? Does your patient get a long-term psych follow-up, or just one time before surgery and clearance?
No, before surgery, it's not only one time. It's a work at least of 6 months in order to get ready for surgery, in between 4 to 8 months preparation, depending on the patient, and depending also on the patient's age. Dealing with a teenager, 17 years old, it's the same like an adult. Yeah, it's the same like an 18 years old. But dealing with a 13 or 14 years old female patient, it's a different issue. So it takes time, not only to be sure what happened with the patient, but also to be sure what happened with the environment, and trying to make some changes before surgery. So before surgery, it's around 6 months of preparation. And after surgery, it depends. I don't have long-term psychiatric evaluation or support. Most of them get either social worker, psychologist, or psychiatrist around 2 to 3 years after surgery. After that, it was either not necessary or not possible.
Great. David, how you explain that your outcome in adolescent much better than adult? So we do know the adult about like 1/3, maybe more than 1/3 of a sleep in adult can have some form of weight regain or GERD. Here you have 2/3 of your patient, 10 years follow-up, they are not obese anymore.
Yeah, it surprised us also. You know, the results are really good. I think that's an issue of early intervention. Okay, if we look at obesity as a chronic disease, I assume and I hope that if you get early intervention, you will get better results. Probably it's an issue of conditioning. What happened with them later on? They started really to change the lifestyles and start to do, you know, different lifestyle, more physical training, and you know, changing their habits. Probably this is the answer.
Talk about physical training. I think everybody of us doing very good job in preparing the patient, taking care of the patient before and after surgery and during surgery, of course, and also adding a diet. What about exercise? Do you have any form of guidance trainer for this such kids about exercise? And this may explain why you have a good outcome in adolescent than adult, maybe young, more active, maybe more support at home?
Well, I can't answer this question. We don't have an established physical trainer in our program. I don't know any program in Israel who has a special trainer for this patient population, but I assume that because they are young and they change their habits before, I hope that this is the answer.
Great. Let's just talk about complications. You have one leak, localized leak that was drained by IR. Long-term outcome, GERD after sleep is a big thing, you know, and we published about that, I think like 10, 15 years ago about sleep migration. Good number of patients after they lose weight and you get uh, losing up all the ligament that holding the sleeve down and you find the sleeve go up and patient can present with bad GERD. So can you share with us your protocol for GERD after sleeve? How you manage that?
Well, you know, I don't think it's a difference in between this patient population and adults. We put all our patients on PPIs for 3 months after any bariatric procedure. And as you see in my article, we get 23% of our patients got GERD. The good thing is around 1/3 of them, around 30% of them has, you know, mild GERD. They did okay with once in a while PPIs and some change in diet. More than 50% of them require a day-to-day basis PPIs, and we had one patient that underwent revisional surgery to NY gastric bypass due to weight regain and also severe GERD. So this is an issue. GERD is an issue after sleeve gastrectomy, not only in adolescents. I am happy. I just read an article that was published last week in JAMA about the incidence of gastroesophageal cancer after bariatric surgery, and we know that it's okay. Long-term follow-up of patients who undergone bariatric surgery, there is no difference in between the incidence in between patients without bariatric surgery and with bariatric surgery regarding carcinoma or adenocarcinoma of the GE junction. GERD is an issue, and you know, we are operating those patients when they are, you know, almost kids, and they have more years to develop GERD, and also the complications of GERD. So yes, this is an issue. We need to follow them and, you know, see what happened. But at least only 1 out of 31 patients needed a revisional surgery for that.
Great. Let's just move on to the gallstones. You have 22% of your patients develop symptomatic gallstones, and they underwent laparoscopic cholecystectomy. Do you use any gallstone prophylaxis, Ursodeol or anything
No,
like that?
no. I tried to do it many years ago in the adult population. They were not compliant on that. It was very difficult for me to get them to get the Ursolite, and I didn't even try in the pediatric population. So no.
Yeah. Okay. So you don't use Ursodeol. But you have 3 patients, 3 out of 31, that's almost like 10% of patients required revisions surgery. Again, in adult, we see more number than that. I see patient coming to me, with weight regain, whether my patient or coming from outside, they lost weight, then the weight start to come back. And when you do a image, and you scope them, you're able to retroflex the scope, means the sleeve is wide. You can have some cases with retained fundus, retained antrum. So how you explain your low rate of weight regain and revisional surgery?
Well, also I don't have a good explanation of that, because if I see what happened with my adult population, I have more than that. Okay, I think that if you ask me, I assume that more or less my patients, my adult patients, will get in between 20 to 25% of revisional surgery, maybe even more. And I think, beside the technical problems that could be done during the initial operation, retained fundus, or a big sleeve, it's a problem of behavior, I think. And I think that the more we wait, and as time goes along, we will get more patients regaining weight. I assume that if I will wait 5 more years, I will find a small group of those patients regaining weight. So, probably the 30% of patients that we don't have the long-term follow-up, probably one of them or 2 of them already get revisional surgery, and the numbers will be completely different. So I don't think that we can get strong conclusions on that based only in 31 patients.
Great. We have another question from Dr. Hamfis. Dr. Hamfis is very involved with Ifso webinar. Congratulate him. He said, if your son has obesity and has GERD, you still doing sleep on him or her, your son or your daughter?
Well, I don't know. I really don't know. It depends how old will be my son or my daughter. I will, I think that today I will recommend it not only for my son. Today, if a young patient, let's say 15, 16 years old, severe GERD, I will recommend a Roux-en-Y gastric bypass. At the beginning, this is a cohort from 2012 and 2015. I was a little bit afraid to do a Roux-en-Y or to offer a Roux-en-Y gastric bypass in this patient population. Nowadays, we have enough literature. We have the AMOS study number 1, the AMOS study number 2, and other studies comparing sleeve gastrectomy and Roux-en-Y gastric bypass, and the results are more or less the same. And I assume if I do and I will offer a Roux-en-Y gastric bypass in an adult patient with severe GERD, I will do the same thing in a pediatric patient. My experience with GERD in really young patients, it's not too big, but yes, severe GERD, I will offer a Roux-en-Y gastric bypass.
Great. So we still
not
have
a gastric bypass.
All right.
Roux-en-Y gastric bypass.
Yes. So if somebody has severe GERD, gastric bypass is always the answer, whether a patient has a previous sleeve gastrectomy or a patient coming for the first time. So Manuela, can we send the questions again? The multiple choice question, Manuela, please. So let's see the first question again. What holding you from doing bariatric surgery in adolescent? Not familiar with patient selection, not familiar with procedure selection, not familiar with preoperative workup, afraid from complications on such a young age, or none of the above. I'm ready, I'm considering, I'm gonna do it. That's great. So comparing before and after, so before with 39%, 39% they said, you know what, I'm gonna do it, I'm ready. Now it's 68%, so almost increased by 1.8%. So that is a very good change after excellent presentation of Dr. Hazan and our discussion. Can we go to the next question, Manuela? So next question about similarity between adult and adolescents in regard of patient selection, procedure selection, follow-up protocol, diet protocol, and pediatric behavior specialist for support environment. So at the same time, David, we have a question here about yeah, do you do a bone scan after 10 years? This question coming from Christina Newwood.
No, I do not. Routinely, I do not. Probably I should, but we don't do it.
Okay. That's great. It's 81%. Manuela, can you send me the first answer? So 81% get it right. I think this is much better than before. So a lot of similarity between adolescents and adult bariatric surgery, but the main difference is the psych support, is a behavior support to guarantee a supportive family and environment. Manuela told me it was 60%, now went up to 81%. That's great. That was E. Yes, great. Okay, so to summarize, you know, a lot of similarity between adolescent and adult bariatric surgery. This segment of obese population is rapidly growing. So we keep focus on adult. I think we need to put more attention to adolescents. In the United States, 4.5, as you show, David, 4.5 million adolescents suffering from obesity, and metabolic and bariatric surgery is the only way for long-term work effectiveness. And the key thing, early intervention, because if you leave them alone, they're gonna get all these comorbidities, and as you show, David, it will decrease the life expectancy by 22%. Very interesting also, David, about patient satisfaction. You want to tell us more about, you sent a survey about patient satisfaction. You have 8.9% from 1 to 10.
Yeah, you know, it was a simple question, you know, not a very complicated question that we asked those patients 10 years in a follow-up of 10 years. And the question was, are you satisfied with your surgery? If you will be willing to do it one more time if you had the opportunity? And most of them were really satisfied with the surgery. The results, okay, are very good for them, for most of them. So yes, I think that if we can use this platform to encourage bariatric surgeons to start doing adolescent bariatric surgery, I think we are doing our best for the community here. I think that we, the adult bariatric surgeons, has the experience, has the knowledge to do that. And you know, probably don't start to do it with a 12-year-old female patient, but you know, start doing it with teenagers, 16, 17 years old patients. And later on, if you build your team and you will feel comfortable to do it, so try to go down as your team will support you, and do it, because we are dealing with this patient population, and if we will not do the surgery when they are 16 or 15 years old, we will do it when they will be at 20 or 21 years old, and probably it will be a little bit difficult to change their habits. And I will focus on one more important point for me. I am a surgeon, but the issue of depression, it's very important. Most of those kids are depressed, and depression is a very, very, very complicated disease, very difficult to treat. And if they continue to be obese, it's almost impossible to get out of depression and in those patients. So yes, I think that I will try to motivate you to do it, and yes, to start to do it, as much as you can.
I think, David, you brought a very important point about sensitivity. Kids in schools, they can harass each other about about the way they look, the way they act. So it's very important to intervene early, to not only for medical issues on life expectancy, but also for psychological and the well-being of the kids. I would like to remind everybody that this webinar will be it was recorded and will be available on Ifso website and YouTube channel, hopefully in a day or two. David, the last question, we don't have any question from the audience, but how you see your volume? Is your volume of adolescent bariatric surgery going up or the same? Or?
Well, not really going up. It's more or less the same. It didn't increase in the last year, but I do a fair amount of adolescent patients. Not a lot of them younger than 15 or 14 years old, but yes, I am still doing it. But a lot of them, let's say, younger than 20 or 19 years old. So I don't see a lot of difference in between them. We are writing now a paper comparing this cohort of patients 17 years old or younger to another group of patients between 18 to 21 years old, and I can tell you that there is no difference at all. So yes, if you take in account the formal definition of teenagers, yes, I am doing a lot of it.
Great. I think what we have to work hard on is outreach and networking, educating our colleague, the pediatrician colleague who has a lot of patients. Like in my institution, we have a lot of patients, 16, 17, and 16 and 17-year-old kids act the same like 18. So if you are comfortable with 18-year-old doing sleeve or bypass, so one anastomosis gastric bypass, recommend, yes, you can do it for 16 or 17-year-old. So just a more presentation, more outreach to our pediatric colleague, and I'm sure we're going to get more and more patients. I don't see any other questions. So I would like to conclude this webinar. I would like to thank Manuel and Stephanie for their hard working. Takes a lot of work for them to work behind the scene with David and myself to get this event done. So thank you very much, everybody, and looking forward to join the Ifso Journal Club next month. Thank you. Thanks, David.
Thank you very much.
Thank you.